If you are over 60 and you have had a blood test that came back normal for vitamin B12, I need you to hear something that most doctors do not explain in a standard appointment. A normal B12 blood test does not mean your cells are getting enough B12. And for a significant number of adults over 60, the standard test misses a deficiency that is already causing neurological damage, cognitive decline, and cardiovascular risk. Today I am walking you through why vitamin B12 deficiency is one of the most underdiagnosed conditions in older adults, why the test most doctors rely on is less reliable than most people assume, what the symptoms actually look like after 60, and what to ask your doctor specifically to get a more accurate picture. Stay with me, because the information in this video could change how you interpret your own lab results. Welcome back. On this channel, we focus entirely on health after 60 because the medical details that matter most at this stage of life are often the ones that get the least explanation. Vitamin B12 is essential for 3 systems in the body that become increasingly vulnerable after 60. The nervous system requires B12 to produce and maintain myelin, the protective sheath that surrounds nerve fibers and allows them to conduct signals efficiently. Without adequate B12, myelin degrades. Nerve conduction slows. The damage is cumulative and, in advanced cases, irreversible. The blood requires B12 for the production of normal red blood cells. Deficiency produces a specific form of anemia called megaloblastic anemia, in which red blood cells become enlarged and dysfunctional, unable to carry oxygen effectively. The cardiovascular system requires B12 for the metabolism of homocysteine, an amino acid that at elevated levels is directly toxic to blood vessel walls and is independently associated with increased risk of heart attack and stroke. After 60, the risk of B12 deficiency rises significantly for reasons that are built into the biology of aging. Understanding those reasons is essential to understanding why the standard test so often fails to catch the problem. Why B12 deficiency is so common after 60. Vitamin B12 from food requires a complex absorption process. In the stomach, hydrochloric acid and an enzyme called pepsin separate B12 from the proteins in food. The freed B12 then binds to a protein called intrinsic factor, produced by cells in the stomach lining, and this complex is absorbed in the small intestine. After 60, 2 things happen that disrupt this process. First, the stomach produces less hydrochloric acid. This condition is called hypochloridria, and it is extremely common in older adults, often without any symptoms. When stomach acid declines, B12 cannot be adequately separated from food proteins. The result is that B12 passes through the digestive system without being properly absorbed, even when dietary intake is completely adequate. Second, a significant number of older adults develop atrophic gastritis, a chronic inflammation of the stomach lining that further reduces both acid production and intrinsic factor output. Without intrinsic factor, B12 absorption drops to near zero, regardless of how much is consumed in the diet. Beyond these age-related changes, certain medications widely used by older adults directly interfere with B12 absorption. Metformin, one of the most commonly prescribed diabetes medications in the world, has been shown in multiple studies to reduce B12 absorption by interfering with calcium-dependent uptake in the intestine. Proton pump inhibitors such as omeprazole and lansoprazole, taken regularly by millions of older adults for acid reflux, reduce stomach acid and directly impair the first step of B12 absorption. H2 blockers, including famotidine and ranitidine, have a similar mechanism and a similar effect. Why the standard blood test misses the problem. The standard test for vitamin B12 measures the total amount of B12 circulating in the blood. What it does not measure is how much of that B12 is actually being used by the cells. Here is the clinical problem. Approximately 20 to 40% of the B12 in the blood is bound to a protein called haptocorin, sometimes called transcobalamin 1. This fraction is metabolically inactive. It cannot be taken up by the cells. It does not contribute to nerve maintenance, red blood cell production, or homocysteine metabolism. Yet it is included in the total B12 count that the standard test reports. The result is that a person can have a total B12 level that falls within the normal reference range, while the metabolically active fraction is critically low. The cells are not getting what they need. Damage is accumulating. But the standard lab report shows normal, and the deficiency goes undetected. 2 additional tests provide a more accurate picture of functional B12 status. Methylmalonic acid is a compound that accumulates in the blood and urine when B12 is functionally deficient at the cellular level, even when total B12 appears normal. Elevated methylmalonic acid is considered the most sensitive available marker of true B12 deficiency. Homocysteine levels also rise when B12 is inadequate, since B12 is required for homocysteine metabolism. Elevated homocysteine in the presence of normal total B12 is a strong signal that functional deficiency is present. If your total B12 has been tested and found normal, but your symptoms are consistent with what we are about to describe, ask your doctor specifically for methylmalonic acid and homocysteine levels. These are standard laboratory tests. They are not experimental. They are simply not ordered routinely. What B12 deficiency looks like after 60. This is the part that makes B12 deficiency particularly difficult to catch. Its symptoms develop gradually and overlap almost completely with conditions that are already on every doctor's radar for older adults. Neurological symptoms are among the earliest and most significant. Tingling or numbness in the hands and feet is often the first sign of B12-related nerve damage and is frequently attributed to diabetic neuropathy or poor circulation. Difficulty with balance and coordination, particularly in the dark when visual cues are removed, is a direct consequence of posterior column degeneration in the spinal cord, a recognized complication of prolonged B12 deficiency. Weakness in the legs that has no clear orthopedic explanation may have a neurological origin rooted in B12 status. Cognitive symptoms are equally important and equally misattributed. Memory difficulties, slowed thinking, difficulty concentrating, and mood changes, including depression and irritability, are all documented manifestations of B12 deficiency. In some cases, these symptoms are severe enough to be mistaken for early dementia. The critical difference is that B12-related cognitive decline is reversible with treatment when caught early. Dementia-related decline is not. This makes B12 evaluation an essential step before any dementia diagnosis is finalized in an older adult. Physical symptoms include persistent fatigue that does not respond to rest, a sore or inflamed tongue, mouth ulcers, and pallor or slight yellowing of the skin in more advanced cases of megaloblastic anemia. What to do if you suspect deficiency? First, request the additional tests. Ask for methylmalonic acid and homocysteine in addition to total B12. If those markers are elevated, functional B12 deficiency is present regardless of what the total B12 level shows. Second, if you take metformin or a proton pump inhibitor, tell your doctor that you are aware of the absorption interaction and ask whether your B12 status has been adequately monitored. The American Diabetes Association recommends periodic B12 monitoring for all patients on long-term metformin. Not all physicians implement this recommendation. Third, understand that if deficiency is confirmed, the form of replacement matters. Oral B12 supplements in high doses can be absorbed through passive diffusion without requiring intrinsic factor and are effective for many older adults. Sublingual and injectable forms bypass the digestive absorption process entirely and are appropriate when atrophic gastritis or pernicious anemia is the underlying cause. Your doctor should guide which route is appropriate based on the mechanism of your deficiency. Have you ever been told your B12 is normal but continued to experience symptoms? Leave a comment below. I read every single one, and your experience might be exactly what someone else watching this needed to hear. If this was useful, share it with someone over 60 in your life. B12 deficiency is one of the most correctable conditions in older adults, but only when it is correctly identified. And if you are not subscribed yet, new videos every week focused entirely on health after 60. No ads, no products to sell. I will see you in the next one.